Chapter 11, Video 3. In this video, we're going to talk about Mobitz 2 second degree AV block. With Mobitz 2, this is a little bit different. The block caused by the block is caused by an intermittent block at the AV node or the bundle branches. Okay, so the block can happen in the AV node or the block can happen in the bundle branches. And remember in video 1 I showed you on figure, I think it was 11.2, where we talked about the AV blocks. It can happen in the AV node or it can happen in the bundle branches. This is where that comes in with Mobitz 2. If the AV node is blocked, if the block is happening in the AV node, the QRS complexes are going to be narrow, okay? So when we're looking at this and we see that narrow QRS complex following that P wave, we can think this block may be happening in the AV node. If the block is happening in the bundle branches, the QRS is going to be wide because that's down on the ventricular side of things. So if it's in the bundle branches, we're going to think, we'll know it's in the bundle branches because we can look at that QRS and tell that it's wide, that the problem is happening down in the ventricles, okay? Usually Mobitz 2 patients already have a bundle branch block, meaning this does not let the impulses get through, and it's dependent on the other bundle branch to conduct the impulses. If that second branch becomes blocked, then none of these impulses are going to get through. With the Mobitz 2, it looks like a sinus rhythm with all the P waves in place, but with some of the QRS waves and the T's being removed. In Mobitz 2 second degree AV blocks, the rhythm originates in the sinus node, giving us those P waves, okay? So going on over, looking at the criteria, our rate is, the atrial rate is 62 in 100. The ventricular rate varies. It's less than the atrial rate due to the dropped beats. It can be regular or irregular or regular but interrupted, okay? So we've got several variations there that this could show up with on our criteria. The P waves tend to be upright, matching. Some of these are blocked or hidden. All the P waves except the block P's have QRSs behind them. The PP interval here is regular. Again, some of the P waves may be hidden in the QRS or the T waves, so we want to look for those footprints in the sand that we call it. The PR interval here, the PR interval is constant on the conducted beats, okay? The QRS is less than 0.12 seconds if there's no bundle branch block, meaning if that block is happening in the AV node and it's not happening in the bundle branches, that QRS is going to be less than 0.12 seconds. If it's happening in the bundle branches, then we're going to see a QRS that's greater than 0.12 seconds. The causes here, again, could be myocardial infarction, conduction system lesions, hypoxia, different medications, decreased cardiac output, and if we have a decreased cardiac output, that could be an adverse effect of this, and it can progress to a third degree AV block if it's left untreated. The treatment here is going to be immediate transcutaneous pacing if the patient is symptomatic. We may give atropine, epinephrine. They may have to put in a pacemaker. We may give oxygen, and they may give dopamine if the pacemaker is not available, okay? So let's think about this. How are we going to know if we're going to use atropine versus epinephrine? With a narrow QRS, less than 0.12 seconds, atropine is going to work best because this area, the block, is up in the AV node and up in the atriums. If we have that wide QRS that's greater than 0.12 seconds, epinephrine is going to work best because it's down into the ventricles. Atropine works best if the block is in the AV node. If the bundle branches it speeds up. Atropine works best if it's in the AV node. If it's in the bundle branches, it speeds the impulses down, but it still doesn't fire, okay? So the atropine does not have that direct effect on the bundle branches. So atropine works best if it's up higher in the AV node and in that atrial area. We want to give epinephrine if we feel like it's down in the bundle branches because it works best on the ventricles. So flipping to the next slide, let's take a peek at this. We're going to ask ourselves the same very questions that we've always asked. Is the QRS here? Yes, and it is regular. What is the heart rate? We have a heart rate of 44. The P waves are upright. They do match. Some of these do not have a QRS. The PP interval here is regular. We have an atrial rate of 137. And the PR interval here is constant, 0.12. And the QRS is 0.12. So then we know by looking at all of our criteria and looking at our choices, we can tell that this is Mobitz 2 second degree AV block. If you have any questions about that, please let me know.